Welcome, and thank you for standing by. All participants will be able to listen only until the question and answer portions of today's conference. To ask a question, please press star one. Today's conference is being recorded. If you have any objections, please disconnect at this time. I would now like to turn your conference over to Ms. Karen Francis. Ms., you may begin.
All right. Thanks, operator. And good afternoon, everyone, and welcome to the second webinar for the 2018 Rural Behavioral Health Webinar Series. Our webinar today is entitled The Impact of the Opioid Epidemic on Children and Youth in Rural Communities, How Schools and Communities Are Responding. My name is Dr. Karen Francis, and I am a principal researcher at the American Institute for Research, as well as lead for the Rural Behavioral Health Initiative, along with my colleague Joyce Sabian and Laura Fleetwood from the Mental Health Promotion Branch at SAMHSA. This webinar series is supported by the Mental Health and Promotion Branch at SAMHSA in collaboration with the American Institute for Research and Affirma Solutions. And Joyce, I just wanted to invite you to say a few words in this second webinar here.
Sure, thanks, Karen. I'm Joyce Sabian, and I'm with the Mental Health Promotion Branch, one of the project officers and public health advisors. And along with Karen and our team with Laura and others, we've been doing these rural webinars for quite some time, probably 7 or 8 years. So I welcome all of you, those who've been on before and those who might just be joining us for the first time today. This is the second of our 2018 webinar series, and we typically have about 4 webinars, so watch for upcoming opportunities. Karen will probably mention those as we go along today. And I'm so pleased that we can focus on this important topic. It's devastating in so many communities and has such implications for families and young people. Again, such a very important topic, and we're hearing from many of our grantees how it's affecting your families, children, and the overall community. So we really hope that it's a very valuable time spent for the webinar. I'm thrilled with our speakers. They bring a rich knowledge and experience. We have kind of a treetop view, and then we have Grace, who's on the ground and in the field and doing the work in Greene County, Ohio. So I'm just going to be welcoming to all of you, appreciate your participation, and thank our speakers, and I'll pass it back to Karen.
All right. Well, thank you so much, Joyce. Joyce, I think you're right when you say that, the issue of opioids and opioid use in rural communities really requires our immediate attention and, quite frankly, our continued attention as we seek to address the problem through not only prevention but intervention, services, and support. And so this afternoon, both our presenters will do just simply that for us. So our presenters today is my dear colleague from the American Institute for Research, Jennifer Loeffler-Cobia. She's a senior researcher at the American Institute for Research. And then we have Grace Schoessow, the Early Childhood Mental Health Coordinator in Greene County Educational Services in Ohio. And of course, I will serve as a facilitator for this afternoon's webinar. So as is customary, as with the webinars today, I want to just talk just a bit quickly about what we want to accomplish over the next hour and a half. Is that today we'll talk about the impact of the opioid epidemic in rural communities and present some data that relates to the causes and the drivers of the opioid epidemic. We'll also talk about federal, state, and local efforts to address this crisis in rural communities, just remembering our focus always on rural communities around the piece of prevention, intervention, treatment, services, and support. And Grace will talk about the role of schools and community-based organizations in addressing this issue as it relates to our children, youth, and families in rural communities. And of course, we will end the webinar this afternoon with the delivery of providing you with some information about resources that you may be able to access to also help in the, as you address the opioid epidemic in your own communities. And I think Joyce had something very important to say to add to this here, right?
Yes, I just wanted to add that one of the things that is particularly important to us here is that in a lot of the literature and a lot of the attention that is going to the opioid crisis is focused on adults. And of course, adults are part of families, but we want to bring more attention to how this epidemic is impacting children. And so, and of course, rural areas have been very hard hit, and Jennifer will be talking more about that. But we really wanted to take some time to really bring the attention to how this is affecting children. And I welcome and encourage you to share, as you're listening to the webinar, some of your experience and strategies, comments, however you want to contribute. So we use this to learn as well as through our speakers. So we hope that we can learn from you too.
Well, thank you, Joyce. So before we get started with the actual webinar presentation, just a couple of housekeeping notes here. We invite you, as we always do on webinars, to ask questions. And today you'll have several opportunities to do so as we go through the presentation. You can ask your questions of our presenters by typing your question into the participant chat box that is located at the right-hand side of your computer screen. We will try to respond to as many questions as time permits us today. Please also note that the webinar, both the PowerPoint as well as the audio for this webinar today, will be posted on the Rural Behavioral Health web portal in about a week or so from now. And at the end of the webinar, I will also provide you with a link for the Rural Behavioral Health web portal. Now, just a very small reminder, we ask that you mute your phones during the presentation so as to avoid any background noise as the presentation is being given. Also, please do not put us on hold, as we may be able to hear the background music or messages that are recorded on your phone system. So without further delay, let us get started with a few polling questions. We want to learn about the participants joining us today and for this call and where in the country you're located. So our first polling question asks, in what region of the U.S. is your community located? And we'll just take a minute or so to allow you to respond. Okay, and thank you for your response. It sounds like that we have the majority of our participants are joining us from the Midwest today, and then, with the Northeast and Mid-Atlantic, we have a few participants joining us from the South and Southeast, and a few from the West and Northwest. So again, welcome. Now, our second polling question, to give us a sense of, the roles that you play in the communities or in that are jurisdictions in which you live and work. We wanted to ask if you could just let us know what's your role in your program or in your community. And we have some choices there. If there are roles that are not represented here on the screen, then you can select other. And we'll just give a minute or so for the response to that. All righty, and I see that we have quite a bit of management and managers and administrators who have joined us today on the webinar, some clinicians and service providers. We have family and youth that are also on the call, some state, federal, and local representatives, individuals from community-based organizations, and small number of participants that represent faith-based or advocacy organizations. And so the third polling question, to set the stage before I turn the presentation over to you, Jen, is that we wanted to ask, as you take a look at in the communities that you are currently living and working in, are you familiar with any strategies that are currently being implemented in your community to address the opioid epidemic? Now, this polling question will allow you to select more than one response. So if there are any strategies, if there are multiple strategies that you know of that are being implemented in your community, please feel free to let us know what those are. All right. So it looks like, from your responses that a number of the strategies that we have listed here are being implemented in communities across the country. We also see that there are a number of our participants who don't know or are not sure of what the services or supports that are available in the communities. So we will have, opportunities to be able to talk about what some of these strategies are and what they look like as they are implemented within a rural context and a rural setting. So with that, Jen, I get to turn this webinar over to you.
Great. Thank you, Karen. I'm excited to be here with everyone today, and just to give everyone a little bit of background about who I am and what I do in the opioid space is I've been working with communities across the country, really, and a little bit of international work in opioid prevention and reduction planning, and really going in and helping communities use data to really identify what are the need areas, what are some of those problem areas that are really impacting your communities, and how to identify the drivers of those. And I noticed as we were taking the poll, we're all in different areas of the country. And with that comes different drivers of what is driving the opioid epidemic or crisis in our different communities. So for instance, what's happening, maybe in New Hampshire, the drivers are different than what might be happening in Boise, Idaho. And we need to really learn to be able to use data to understand what is happening in our communities, what's driving the issue, so that we can apply evidence-based practice solutions that match our community needs. So we're not trying to put a one-size-fits-all, so to speak. So that's what I've been able to do through the Opioid Center that we have here at the American Institutes for Research, is really helping these communities understand their problem areas, their drivers, and then really helping map evidence-based practice solutions and implementation. So as we go through my portion of the presentation, I want you to keep in mind, just kind of in the back of your head, a couple of things. One, thinking about your communities and where you work and your role in your communities. What's the data telling you in your communities? What the problem areas of the opioid epidemic, and I'm going to go through some just overview general statistics, but again, it's about what's happening in your communities and using your own data. And then also keeping in mind, what are some of those drivers? What could be causing or having correlation, so to speak, of these problem areas? And then the other thing I want you to keep in mind as we go through some of the statistics, and I don't want to overwhelm you with a bunch of statistics, but I do want you to understand the overall issue that we're seeing in opioid deaths, prescribing rates, and how does that equate into rural versus urban, and then also how does that then impact our youth and our families. And give you just that general sense, and then we'll talk a little bit about, some example drivers and some examples of projects that I've been working on within the states. The other thing that I want you to keep in mind as well as we go through this, and also when Grace is talking, is keep in mind that as you look at statistics and data about the opioid crisis, think about they aren't just numbers. Every number is a person, and every person has a story. And I'm sad to say that probably most of us on this call probably know directly of somebody that has been impacted, whether it's been through misuse and abuse or more unfortunately through death. But we all probably have a story that we could tell of how we have personally been impacted by this crisis. So keep that in mind as we move forward. We're truly trying to look at data to help us get a better understanding of what's going on so that we can apply better solutions and really hopefully make a big impact on reducing and preventing this problem. Karen, you want to go to the next slide, or whoever's, oh, there you go. So like I said, I'm going to go through just some overview of general national statistics, and then we'll start breaking it down a little bit, and then we'll start getting into the nuts and bolts of drivers and solutions and how we might be able to do that. So just overall, and nothing probably that I'm going to say with these statistics might surprise you, but, currently we have declared, this a national public health crisis. So I equate this a lot to our tobacco crisis from years ago. It's kind of similar what we're going through now with the opioids. Back in the 80s or so, even 70s, 80s, we started to learn a lot more about tobacco and the harmful effects that tobacco had on our health. And through that came policy change, legislation change, practice change, but that took, a number of years. We're now at 2018, and we're still working on, some of the tobacco practices, but we are in a much better place, and we're seeing a decrease in numbers as far as deaths and tobacco-related diseases. So keep in mind that as we're moving into this opioid public health crisis, we are just in kind of the starting process of this, and so we need to start thinking about it in terms of how can we change policy practices, just as we did with the tobacco crisis. So just to give you a kind of a sense of the severity of this, more Americans are dying every year from drug overdoses related to opioid deaths than we have from motor vehicle crashes. Next slide. So here's just some general an overview of some national statistics. Drugs involved in U.S. overdose deaths. So you can see clearly from this, from 1999 to 2016, our opioids are having a huge spike in opioid deaths related to other types of substance abuses. Next slide. And I just want to give you a visual as well. So when we look at the number of drug overdose deaths by each state, this was in 2014, so just 4 years ago. So you can clearly see that some of the, red states like Utah, New Mexico, Ohio, Pennsylvania, New Hampshire, even back 4 years ago, were having higher opioid deaths than other states. But if we jump ahead to 2018, so next slide, or 2016, you can clearly see that dark red is filled in a lot more. So just in the 4 years from, the 2 years from 14 to 16, you could clearly see that we are having a large spike in opioid-related deaths among the U.S. Next slide. And again, just another visual from 2006, we look at the opioid prescribing rate. So these aren't necessarily deaths, but just how opioids were being prescribed back 12 years ago. And if we jump back into current times of 2016, you can clearly see a visual of how our prescribing rates have changed in relationship to opioids. And I just want to go back to that slide again. If you'll go back. So here we are in 2006 and how opioids were being prescribed, and then we jump to 2016, and you can clearly see that we have higher rates of opioids being prescribed, which in turn is part of the issue that we're seeing with our opioid deaths. And the reason why I do this is to jump back and forth between slides visually is because a lot of times when we look at data, sometimes it can be hard to look at this map and think, oh, what is going on here? There's so much going on this map. I want to be able to help communities learn how to visually look at their data and get an understanding of where the problem areas are. So if you think through where you live right now and you're looking at your state, and just, not putting anything in the chat box or anything, but just thinking about your state, can you clearly see as we jump from 2006 to 2016 where some of those opioid prescriptions have increased? Next slide. Great. So if we think about in terms of, okay, well, how does this then, we know nationally, right, that we have a large problem in opioid prescribing, misuse, usage, and also death rates, unfortunately. So how does that start breaking down into our rural areas versus our urban areas? Where are we seeing the death rates? And again, keeping in mind, as I said at the beginning of my presentation, all of these statistics are numbers, yes, that we see, but each number represents a person, and each person is representing a story. There's always a story behind these statistics. So just, continue to keep that in the back of your mind. So overall drug overdose deaths, obviously we've talked about are rising in rural areas across the U.S. And we're seeing a greater increase in rural areas versus our urban areas. And we're going to talk about in a minute what might be, some of those drivers that are causing this spike in our rural areas versus our urban areas. But overall, people living in rural areas are 4 times more likely to die from an overdose currently, as far as 2015, than they were in 1999. Next slide. And if we think about it with our rural versus urban and our young people versus adults in our rural areas, so nearly 8% of rural youth, those ages 12 to 19, and 9.5% of rural young adults, so a little bit older, 20 to 29, had used opioids in the past year, compared to rural adults, 5%, 30 to 49, and then 1.5%, 50 and over. So not only are we seeing a spike in just rural areas overall, having more issues of opioid use and misuse and even deaths, we're also seeing an increase of rural youth getting involved in using opioids, which is a great concern. Next slide. And again, if we think about it in terms, and I know I've been talking about use, the action of use, we have to think about this as our children, youth, and families as well, because just because somebody isn't using, I'm hoping, we don't have a lot of data on this, but I'm hoping that we don't have a lot of 5-year-olds using opioids. I'm going to talk about that in just a minute. However, we are seeing an indirect impact of families, parents, older siblings using opioids and how that impacts the kids. So right now, from 2005 to 2015, we see a 10% increase of those kids entering foster care, do so because parents are using the opioids. They've been put in jail, they've been arrested, the kids have been removed from the home, those types of situations. So while the kids are not necessarily using the opioids, thank goodness, but they are being impacted because of their guardian or parent abuse. So we're seeing a large increase in those kids entering foster care. Next slide. And again, just to put a little bit more perspective on the children, youth, and families, at least 2 million children annually have a parent who are using these illicit drugs that include opioids. So that's an estimate, and then also an estimate of 21,000 pregnant women, so that ages 15 to 44, are annually misusing opioids during the month of during their pregnancy. And this was just for a survey that was conducted by the National Survey on Drug Use and Health. So that's a large number of kids. I just want you to let that sink in. 2 million children have a parent who are using some kind of illicit drug, which is including opioids. And so while, like I said, the kids may not be using, hopefully, these younger kids, they're learning these behaviors, they're learning that this is okay, and then we are seeing that increase as they get older into young adulthood and adults, that they also have a drug opioid issue as well. And it's just another statistics, between 2002 and 2007, an estimated 2.1 million children under 18 lived with a parent who was dependent on or abused illicit drugs. So just some statistics to keep in mind as we're thinking about how do we work with children, youth, and families. We have a lot of youth that are being exposed to this epidemic at a very early age. Next slide. And again, just some more, just different statistics to keep in mind. These youth that are living with parents who are using or addicted to opioids. So infants with mothers who use opioids during pregnancy are more likely to have a range of physical behaviors, like I just talked about, behavioral cognitive problems. So one, they're learning the behaviors of this is okay to do based on their parents. But then they're also learning a lot of cognitive problems. They have cognitive problems, which down the road can lead into juvenile delinquency, things of that nature. Also, we are seeing an incidence of a neonatal abstinence syndrome, or NAS, which has increased by 300%. And again, let that sink in. We're not talking about 10% here, but 300% between 1999 and 2013 of births that are children being born with NAS. So these are kids that are being born that are, in essence, addicted to opioids and have to go through the withdrawal symptoms and really try to recover from their addiction that they developed from their mother. And again, substance abuse can also result to, obviously, ineffective or inconsistent parenting. I don't think that that's a surprise to anybody as far as if, we have parents who are using and abusing opioids or any other substances for that matter. They're probably not going to be the most consistent parents. So, we're developing youth in that type of environment. Next slide. So if you think about, and this is something, and I'm not sure if the chat box is pulled up yet, but if you think about this in your communities, and I know I went through that since we have a time limit here, but I went through those statistics quite fast. But think about in your communities where you live and what your role is, and the data or the information that you know about the problem areas in your communities. What types of drivers, or what do you think could be impacting the increase in opioid use, misuse, and death rates that you're seeing in your communities? And if you want to go ahead and, I don't see the chat box pulled up, but if you want to pull that up and let folks put in the chat box.
Yes, so the chat box is up, Jen, and just invite anyone who wants to respond just to type it in, their response into the section. It's on your right-hand side of the screen, and yeah. All right.
Seeing lack of hope and aspiration.
Oh, yes, okay.
Yep.
Isolation, yes. Homelessness, lack of MAT. Ooh, they're coming in fast. You guys are.
All right. Economic hardship, unemployment, targeting of rural communities by large drug companies, lack of jobs, unemployment, lack of resources, transportation issues.
Perfect.
In my experience, that rural areas are more suburban, which means they can afford the habit. There's the issue of stigma that some of our sports injuries, lack of employment and poverty, lack of mental health, boredom, lack of stimulation, lack of opportunity. It's just some of the responses, Jen, that are coming in fast and furious. There's also the issue of around pain management and lack of community, and overprescription of opioids. All right.
Everybody received 100% on that quiz. You all did a great job. If you want to go to the next slide, and I just put up a few here on the next slide, and you all even added in more. And of course, the list can go obviously on and on. And one of the things that I heard that I don't have on my slide is the stigma around opioid use, right? That, the opioids are just, we often hear, are just a street drug. It's just folks that are, homeless living on the street, so there's a stigma around it. And that's not true at all. Opioids are impacting every walk of life, from male to female, young to old, every ethnic background. It doesn't discriminate by any means. So you all had a great running list in your ideas. Just some that I had up here are poverty, limited access to health. You had all said that as well, lack of health insurance, poor health status. Some of you had said injuries, chronic pain, those types of things. Limited education attainment, we just don't know. We're not getting the education out there, and unemployment. So lots of different drivers, and what we need to do is really think through, like I said, really learning how to use our data to understand what like I said, the problem areas, and then what are those drivers within our communities? Because as I used the example before, what's driving the problem in Washington, D.C. or New Hampshire may not be the same as Boise, Idaho, right? So we have to really learn what's driving it so that we can target the right populations and provide the best solutions. The next slide. So thinking about just in even our rural communities and our youth and families, some of the different types of things that we can start thinking about doing is supporting training, right? We need to, and that goes along with that stigma idea. We need to support better training around the opioid epidemic so that people can get a better understanding of what it is, what are opioids, who's it targeting, which is everybody, and what can we do to help prevent this, right? So better training, increased access to treatment. And I know some of the drivers that we put on there, when we're thinking of our rural communities, a lot of our rural communities do not have good access to treatment because those usually pop up in our urban communities, right? So we need to think through how can we make sure or put together in place policies and practices and funding our resources to make sure that we can get these treatments out to our rural communities as well. Working with our public safety, and I'm going to go through a couple of community examples of where I'm working in Massachusetts, Tennessee, and then we're also starting up work in Utah, where public safety is really getting on board to help scale up these evidence-based practices. And so, for example, public safety, police stations and fire stations, are doing more Narcan training. And if you are not familiar with Narcan training, Narcan is a drug that can help reduce the overdose effects of opioids. So if someone's overdosing, they receive a Narcan shot, and it immediately reduces or revises the effects of the opioid that they've taken, and hopefully prevents that overdose or death from happening. So public safety is really getting involved in Narcan training and helping the community learn about that. And they're also, we see a lot of public safety agencies hiring social workers. So as they go out on these overdose calls, they have a social worker that can follow up with that client or patient to get the resources that they might need to help get them into recovery. So that's been really interesting to see happen. Next slide. So what are we doing? This is just an example of, and I'm going to go through 2 community examples here quickly. What we're doing, like I said, we're trying to help communities interpret the data, identify those and prioritize needs, and then identify promising practices. So I just want to show you 2 examples of some community data. So this isn't necessarily national data that I just showed previously, but breaking it down into a specific community. Next slide. So, and again, this is a community data. This isn't national. This is just one community in a state. So when you look at this slide, you can clearly see that we have a spike, and this is looking at the total opioid overdose deaths by age group, right? So we can see from 2015 to 2016, so just in that 1 year period, in this particular community, we had a huge spike in opioid overdose deaths of young people between 25 and 34 years old. And keeping in mind our youth and families and our children, those are age groups 25 to 34, as that's that age group when we are starting to build our families and have young children. So again, you know, this age group of 25 to 34 could also have those young children that are being indirectly impacted by the use and abuse of the parents. So we see a spike, and so this is just an example of data visualization that can just say, okay, we've identified clearly a problem in our community of this age group having a higher rate of opioid death. So now we need to decide what to do about it. Next slide. This is just another example of how to look at your data, and again, this is a community kind of by county example of a state. So the large circles represent the deaths per 10,000 people, and the dark, lighter to darker purple represents the prescriptions being prescribed in those counties. So you see down at the bottom of the slide of the graph, rural area, we have a high rate of deaths and a high rate of prescriptions, where in an urban area, we have a lower rate of prescriptions and a lower rate of deaths. So that starts you thinking through, how do I interpret this data to figure out what the problem areas are? In my rural community, am I seeing prescription and those deaths because we don't have education for prescribers? We haven't done any type of coalition building around this. I mean, what are some of those problem drivers with these problems? So it's just really trying to use our data, visualize what's going on, and then having those conversations so that we can start understanding better the problem. Next slide. And I know I'm throwing a lot at you, but I just want, for this particular presentation, just start thinking about, again, your communities, what's your data telling you, what are those drivers, so you can start mapping those practices. So this just gives you an example. If we think about that first example of the ages 25 to 34 in our community, that we're seeing a large spike of overdose deaths, some of our drivers might be, well, they're not insured to receive treatment, so they're not getting treatment, therefore they're continuing to use and eventually, turning into a death. Or we might have a driver where, campaign materials are not focused on this population. Maybe that it's been focused primarily on a homeless population because we weren't really understanding our data. So we need to make some adjustments to our campaigns. So some of those promising practices can be, Narcan training for first responders, getting that immediate treatment, whether they're insured or not, to those that have overdosed to prevent the deaths. And then we can also focus our prevention campaigns on the dangers of opioid misuse and abuse, and just really targeting that message. And then the other example that we looked at was we had that large rate of increase in number of overdose in rural areas, and the prescriptions were also larger. So some of the drivers may be MAT not available to rural areas, and we may have a presence of several high-risk prescribers. These prescribers do not have a clear understanding of the impact that they're making when they're prescribing opioids for everything. And so some of the promising practices are building those community coalitions, which have been so impactful in rural areas, really getting those coalitions together of prominent stakeholders in the community, leadership, folks that can be a real champion for this effort. Increase access to medical assisted treatment. So, working within your coalitions, how can we get better MAT, and then obviously that prescriber education. So I'm hoping that you see through this that what you are really trying to do is look at your data, what's driving it specifically in your communities, because it's gonna vary from community to community, and then applying those best practices that match up with the drivers. So just quickly before I turn it over to Grace to go over more of a specific example within Ohio, two areas if you want to go to the next slide. Two areas that I mentioned we were working on, really getting in depth within the community on using their data to make these data-driven decisions, is one is in Tennessee, and I've put here what they're calling the Tennessee Together Community Solutions to End the Opioid Epidemic. I put here a website, and again, I believe Karen said that this presentation will be up on your website. So you can go here to this link and read more about what we've been doing in Tennessee. And then also, next slide, we've been working in Massachusetts. And this is a partnership out of the District Attorney's Office, which in and of itself is very innovative to have the District Attorney's Office really kind of fund this type of effort. And you can go to that website as well to learn more about what we're doing in Middlesex County in Massachusetts. And I believe that is the end. So, Karen, do you want them to ask questions now or wait till the end of Grace's?
Yes, can just take a few questions here, Jen. Well, first, just want to let everyone know.
That's the operator. Operator, can you have people sign up for answering questions on the phone?
Yes, thank you. If you'd like to ask a question, please press *1 and you will be prompted to record your first and your last name. Please unmute your phone when recording your name, and to withdraw your question, press *2. One moment.
Thanks, operator. I just wanted to let also everyone know that copies of this slide will be posted on the Rural Behavioral Web portal within another week or to week and a half. And while we're waiting for some questions here, Jen, we had two questions that were typed into the chat. First question, is there a map that shows prescribing rates that does not include those prescribing rates from the Veterans Administration?
So are they asking if there's from the VA?
So in other words, the prescribing, the rates of prescribing outside of the Veterans Administration.
Oh, as far as the source. Oh, you're just asking me about.
Yeah, just the source, right.
Yeah, there are other resources that I can definitely post and get to Karen to put up on your website. Yes, but there are definitely other resources. That was just one source.
Okay. So and then the second.
Oh, go ahead. Sorry, Karen.
Yeah, and then the second question is, for kids entering foster care, is the drug use data specific to opioid or is it for all drugs?
So the data that I showed was illicit drugs, which included opioids, but what we are seeing is that increase in opioid use is having that great impact on those kids going into foster care. So it's a new area of research that we are just diving into to seeing how this is affecting opioids specifically are affecting youth and families. And like I said, the data there isn't around, whether the kids, 0 to 12 years old are using drugs, because hopefully they are not with the opioids, but they're definitely living within, with parents, guardians of those that are using.
Thanks, Jen. So, operator, do we have any questions queued from? We'll just be able to take one question now from the phone, and then we'll move on to Grace's presentation.
I am showing no questions.
Okay, thanks, operator. So, Grace, without further ado, turn this over to you.
Great, thank you. Hello, everyone. My name is Grace, and I'm an early childhood mental health consultant and a certified trauma practitioner. I'm part of the Greene County ESC, or Educational Service Center's mental health team, and my role is an early childhood program coordinator. And I'm so glad to have this opportunity today to share our efforts on lessening the impact of the opioid epidemic on children and families in our part of Ohio. Our work is truly a team effort, and I'm going to be talking today and doing my best to share the work of our local and state partners, in addition to the support and technical assistance and guidance from our federal partners. Rural communities are near and dear to me and to my heart. I live in rural Ohio. I raised my 3 kids in rural Ohio. I live in the middle of a soybean field. In fact, this morning I woke up to the sound of a crop duster, airplane flying loops overhead, I love living in the middle of nowhere, and I never complain about commuting an hour to work each way. And I can recognize how resilient and resourceful rural folks are. We pride ourselves on being able to handle our own problems or know someone who can, and that's an important part of being able to understand what our problems are so that we can problem solve. Usually, or generally, our chief complaint was unreliable low-speed internet connection. That was our chief rural complaint 10 years ago. But now there's a much deeper-rooted problem that's overwhelming our rural communities here in Ohio. It's like a noxious weed in a soybean field. The opiate epidemic threatens every aspect of our rural life, and perhaps the most troubling are the vulnerable victims, the young children that are caught up in the epidemic. So that's what I'm going to talk about today, is the impact and how to lessen the impact on children, youth, and families, and what our project is doing to be able to help. Our future hinges on the social, emotional, mental, and behavioral health of these children. Their ability to develop resilience necessary to overcome years of adverse experiences is paramount. And key to this is rallying our rural communities to help the children of the opioid generation. And it benefits everyone. It benefits the parents that are struggling to recover, grandparents coping with supporting their children who are battling addiction and raising their own grandchildren, and the providers and professionals who are at risk for burnout. And this includes educators, school teachers, child care providers, mental health professionals, behavioral health professionals, medical professionals, nurses. Absolutely everyone is impacted. And often folks are overworked and underpaid in rural environments and wear many hats. But we're all on the front lines and witnessing this gradual tragedy of the opiate epidemic unfold every day. So with that being said, I think we'll advance to the next slide and we'll dive in, and I'll do my best job of trying to cover this important topic. So people in rural communities lead interwoven lives, and their roles overlap and intersect in unexpected ways. Here, everyone's lives are being impacted by the opiate epidemic, and the difference is only to what degree. So not only are the parents directly impacted, but the children and family members are also impacted. And because our lives overlap and intersect, and my professional life, I have friends and colleagues, neighbors, and people that you would not expect that are directly impacted, and all of us are indirectly impacted. When we think about children specifically, their social, developmental, medical needs are all impacted. Early childhood mental wellness is something that our community is striving to address and promote the concept of mental wellness. We'll talk a little bit more about that. We're looking at multi-generational and parallel process of looking at all the levels of intervention. And we also look at the impact that weakened natural supports have on children, the adverse childhood experiences that accumulate over time. Caregivers, teachers, and professionals are all impacted in unique and individualized ways. And again, because of the nature of rural communities, often you have people with overlapping roles. They might be a Sunday school teacher and also a nurse at the local clinic, and also the parent of an addict. So we have to keep that in mind. Next slide. So again, another aspect of when we start talking about children, Jen alluded to this a little bit earlier, we're talking about a very broad range of development from infant, toddlers, preschool age, all the way up to school age children, and then adolescents. So we know the brain isn't fully developed into the mid-20s. So we're talking about a long, wide range when we refer to children. We know that each age group needs to be addressed in a separate and unique way, and it takes a community effort and a collaborative effort in order to be able to address the developmental needs of children. Okay, next slide. So this is some of what we're looking at here in Greene County, Ohio. In our corner of Ohio, we are addressing the need. We had a local needs survey done about 4 years ago when we received federal funding through SAMHSA for Safe Schools, Healthy Students project to integrate our mental health system and our education system locally. The first step was to collect data, look at data, try to understand what the problem was. 62% of our children entering kindergarten were considered not yet ready to learn, according to the Kindergarten Readiness Assessment. And we were also looking at 1 in 4 children not ready for that kindergarten experience and needing additional supports in the classroom. This also meant that we had considerable behavioral health needs happening and an issue with suspension and expulsion and in preschool and kindergarten environments. So when you look at this little map of Greene County here, we have to the left side of the screen, we have the Wright Pat Air Force Base, which is the largest single-site military base, largest single-site employer in Ohio. So that impacts our community quite considerably. And then on the right hand of the screen, it's entirely rural. We have 8 different very unique and distinct communities in it. We have a very diverse set of needs, which makes it incredibly important that we understand each of our distinct communities. Over 20 languages are spoken in our elementary schools. We have 13 colleges and universities. 21% of our children under the age of 5 live in poverty. It's mostly rural agricultural land. So these are kind of some of these background factors that are important for us to understand. Okay, next slide. So as we start to think about how do we address these problems and how do we address these issues, we know that the majority of parents in recovery for opiate addiction cite their children as their primary motivator for staying in treatment. This is an important factor as we think about how do we help provide a full range of mental health services in our community for children and families. Engaging in a parallel process is necessary for change, so we need to help the children that are impacted by the opiate epidemic. We need to help the adults that are caring for that child in order to indirectly help the child. And then we also need to help the caregivers themselves, the people that are providing the services that are at risk for secondary trauma and burnout. And helping them is key to helping the adults and the children themselves. We also focus a lot on positive outcomes and having hope for positive outcomes as a motivator for the difficult work necessary to break the cycle and create lasting change. This is part of our focus. Next slide. So this is a reflective question that I'd like to just throw out there. No need to respond, but I would like you to think about this question. Where does prevention and intervention or treatment begin? A lot of times we think about a linear continuum of services from promotion, prevention, intervention, and treatment. And I would like you to consider that service array being a circle when you're thinking about early childhood. We think about a pregnant mother who might be in MAT or medication-assisted treatment and expecting a child. Her child is going to have needs from the moment of birth. When you think about a newborn and their need for future prevention because they're within a family system that's affected by the opiate epidemic, a young child who's having social, emotional, developmental needs, behavioral health issues, some early signs of long-term mental health needs or issues, where does prevention start, intervention end, treatment begin and end? Perhaps it's a circle, and we need to be offering services across the whole array. These kind of questions and these kind of considerations are part of what we've done as a community in our collaborative problem-solving efforts. Community problem-solving is required in order to remove access barriers and coordinate mental health services across the continuum, and then also to provide that necessary outreach to the other service providers and integrate our services within the education system and the health care system, the children's services systems, so that we can do a better, and juvenile justice, so we can do a better job of providing meaningful solutions. Next slide. You can go ahead and go to the next one. Thank you. So Ohio Safe Schools, Healthy Students, we were a grantee back in 2013. We're just wrapping up our grant work, and we are Greene County. We're part of 3 different grantees in the Ohio community that received the pilot funding. And we've been able to do some things that will leave a lasting impact, and part of the most important aspect is the community collaboration. So we've created a community coalition, and it's called the CMT, the Community Management Team, and we're continuing past the SAMHSA grant. We also have an active drug-free community coalition, Family and Children First Council, and lots of effort and interest in being able to solve this problem, lots of collaboration. Next slide. The key to these interventions and services have been a recognition that families need to be at the center of the services and taking family engagement very seriously. So bringing family, school, and community together to support the social emotional development and this concept of mental wellness, really important as the glue. So in our rural communities, we know that schools and school events bring families together, and by helping create a culture of mental wellness at school, we're able to provide those positive opportunities to engage families and connect the parents and professionals. And so we're expanding beyond connecting just the educators with families, but opening it up and having resource fairs that include all our community partners. With our early childhood initiative, we've been able to identify 71 community partners that have all participated in collaborating to provide resources for families, recognizing that the families of young children are often the most vulnerable. And if you think back to the statistics that Jen was sharing, that high-risk group from 25 to 34 at highest risk for overdoses, many of those folks are parents. Even if they're not actively parenting their children, they are parents, and whatever we can do to engage and support their families, the better we all are. So we work on creating connections and relationships, thinking of the school as kind of the hub for the rural communities. Next slide. So another aspect that is a difficult aspect of this is that we have a number of newborns that are born with neonatal abstinence syndrome or neonatal opiate withdrawal syndrome. It's referred to as NAS or NOWS. 5 years ago, Ohio was recognized as being the opioid epidemic, part of the ground zero, and babies being born addicted and families being pulled apart, parents struggling. 5 years later, we've seen an 11-fold increase of babies being born. And we also have the feedback we're getting from our preschools, child care centers, kindergartners, are that there are children that have long-term impacts, mild cognitive delays, behavioral health issues, there's difficulty in the classroom with classroom management, poor attention span, there are many, many challenges that we're seeing that we do not have an effective way to address at this point. We all are collaborating to try to understand how best to address these issues, and early childhood mental health consultation has been one of the things that has been the most successful in addressing this trend. Next slide. So again, this information goes hand in hand with the last information. So this, again, is this is Ohio specific, the number of infants needing intensive care for NAS. And you can see the jump between 2004 and 2013, 2004 and 2013. And then also have a note on the side that what this translates to is 6,406 Ohio infants being exposed to opioids or hallucinogenics. In 2015, the average hospital stay is 14 days, so 2 weeks to 20 days, costing on average $61,000. So this is having an economic impact as well as having a devastating impact on the outcomes for the children. Part of the piece that we are sensitive to is that we're also trying to destigmatize moms in treatment. So medicated assisted treatment means that some moms are on opioids as a part of their treatment. And we need to effectively reduce stigma associated with being on treatment or in treatment and having a child that is exposed in utero. We don't want that to be a barrier to seeking help and having some long-term help and supports in place for the child that will need some extra help as they move through their development. So we want to make sure that we're connecting with these parents, connecting with these families, and that stigma doesn't become a barrier to accessing the help and services that they need for themselves and for their child. Next slide. So in the rural Ohio, again, this is a heavy-duty image, but it's part of our reality. We have, on average, 6 admissions per day. It's grown 11 times or 8 times from 20 per live birth now to 155 per 10,000 live births in 2015. So the numbers are growing exponentially. We don't know, the research is not yet clear on what the long-term effects are. Active research is being conducted now. We're paying attention to it. We're seeing what we can do. Anecdotally, if you talk to any kindergarten teacher, they will say that this is a different world, a different reality. Kids have more intense behavioral health needs, and it has to do with, in part, the trauma they're experiencing, their insecure attachments to opioid-affected parents, and then also the in utero exposure. So it's a whole combination of things. So I would encourage you to look at the statistics are available in every community. Dive down and look at what impact is this having locally, and what are some ways that you can address it. Next slide. So this is an example of a collaborative. This is a tri-state collaborative that is happening. It started up last year. We have another event happening this fall, and this is an effort to pull together the community that's interested in sharing their research that's hot off the presses, and as it's being actively conducted, so that we can get a better handle on how to start solving this problem now. Since it's impacting us so greatly right now. Next slide. The key recommendations that came out of the summit last year are that we need to enhance child development beyond the initial treatment that shows that they have immediate withdrawal needs, but the effects down the line show these impacts to their social emotional development and long-term educational life outcomes. But the bottom line is we don't yet know. Most of the evidence is we don't have the long-term research yet. So also, we know that prenatal exposure can be mitigated by building protective factors. So with early childhood mental health initiatives, we are very serious about building protective factors. So we provide lots of interventions, preventative services, and then also, when necessary, treatment services in order to be able to address the earliest signs of social, emotional, behavioral health needs for children, and then also build the protective factors and build resiliency in the child and the family and the school system or classroom that the child is involved in. We also need to explore the interventions that enhance protective factors and minimize the adverse effects of neonatal exposure. So this has a lot to do with the outreach that we do with our community partners. And I'll give you an example of the type of things that can happen when you build these collaborative coalitions. I was at a drug-free coalition community meeting, and the sheriff was there, and he talked about how he felt as if they were housing or a garage that was keeping broken down cars when they kept parents in their cells without providing them any type of rehab or any of the types of things that he knows they need, that he wished that it was more like an auto body shop where that they could get fixed up and have some connection to the types of things that they know they need, and specifically asked for parenting resources and some resilience education for the folks that he has that in his jail that need those access to those resources. And that's an easy thing to do, to link up existing services in the community with an identified place that needs them. So that's the type of cool things that can happen when you start to collaborate and openly brainstorm. How do we match up what services that we have available with folks that have people that are in need? Next slide. So this is a snapshot. Again, I have the link there if you'd like to check it out. The 28% of children taken into custody by Children's Services in 2015 in our county had parents using opioids. In Ohio. So in Greene County, so locally, 39% of children in Children's Services custody had parents using opioids. So nearly 40%. So 4 out of every 10 children in our county are impacted. Next slide. So knowing this and understanding what the nature of the problem is helps fuel our desire to be able to more effectively meet the mental health and behavioral health needs of these families. We know that we need to support children developing protective factors, as I mentioned before, in order to address social, emotional, and behavioral health concerns early in childhood rather than waiting later on because they are at greater risk. We know we need to support families. The majority of parents that have children with neonatal abstinence syndrome or neonatal withdrawal syndrome are in treatment. So we need to effectively destigmatize and figure out how to support families effectively. And that is regardless of whether Children's Services is involved, whether the child has been removed, a parent is a parent, whether their child is with them or not. We need to support positive connected parenting through treatment and recovery. We need to develop awareness and empathy, and we actively address blame and shame. And this includes during community meetings, when we're working with providing the professional development for healthcare professionals, mental health professionals, behavioral health educators, child care workers, anyone who's working in a child care, or not child care, but a child caring agency or program we actively address the role of blame and talk about it as a brain-based limbic process. So that helps build empathy and build resilience and wards off against secondary trauma. We also destigmatize the need for services for infants, children, youth, adults, and families. It's not an easy conversation to have with a parent why a child may need behavioral health or mental health services. But it's an important conversation, and it helps to further the cause to destigmatize. And we need to improve access to behavioral health continuum. Next slide. So part of our mission with Safer Schools and Healthier Students has been to understand how these gears affect each other. The turning of these gears is incredibly important. So within our community, we have a large military family component. So that means parents that are experiencing deployment, and we have both moms and dads that alternately deploy. We have the opioid epidemic, and we have this high rate of children's services involvement for abuse and neglect. So many parents struggle with the challenges of modern life. Modern life is hectic and busy, and it's difficult to have the types of routines that help children lead low-stress lives. Dealing with stress makes it hard for parents to focus on their child's social emotional needs, so we're seeing the impact. Many parents, when they're stressed and they're busy, they do things to promote their own self-care. They might spend more time on their cell phone, more time surfing the internet, more time engaging in escape-type behaviors, including drug use, less time building their child's social-emotional skill set, less time engaging in promotional learning activities with their child. And that cumulative effect is that children pick up on the stress, and it affects their behavior. And we see serious delays in social-emotional development and behavioral health issues. Next slide. These are part of the lessons that we are actively learning. This is a process, and we don't profess to have any of the answers. We're just actively in a process of trying to figure this out. We ask a lot of reflective questions, and one of them that is really helpful in figuring out what is the most helpful in a rural community is to ask, who would you turn to if your child needed help? Or who would you turn to if your young family member needed help? This question is answered differently in different communities. Sometimes it's a faith-based leader, sometimes it's a family member, sometimes it's an educator, sometimes it's the family doctor. It depends, and we need to pay attention to how people answer this question and what they consider helpful. Resource mapping and understanding the needs, and then also understanding the roles. In some communities, the local doctor has a lot of clout and a lot of influence. Sometimes in some of our communities, there are no local doctors. It's a nurse at the clinic. In other communities, it might be an administrator at school. Every community has their own understanding of what their needs are and then who fills what role. Important to understand. It's also really important to understand the centrality of relationships and relationship-based services by trusted community members. So this is another big piece of early childhood mental health consultation work, is that the relationships are at the center of the work. It's important that people recognize your face, know your name, can trust that you are someone that they can turn to for help, and that we are creating and establishing those types of relationships throughout the community. So when we provide a mental health service provider in a school, that person is known by their first name, the parents can recognize their face, they're a familiar part of the team, and they're completely embedded within that school. And schools, again, are the primary access point in rural communities, so we need to be taking advantage of that and helping support the schools' efforts to create safe and healthy learning environments. Next slide. The other lessons we're learning, again, the importance of overcoming stigma and barriers, identifying what they are, and thinking about engagement across generations. Trauma-informed care, again, multi-generational. We see many families that's grandparents, great aunts and uncles, even great-grandparents that are raising children. We need to provide outreach that's multi-generational, and therapy and interventions that are multi-generational, and also are on-site or available to overcome transportation barriers, which is another real benefit of being able to provide services at school. And then prioritizing infant and early childhood mental health at the community level, addressing quality of care, child care deserts, early intervention, and preschool expulsion prevention. And if we go on to the next slide, I have included in here, so we do not have enough time to really dive down into this, but on the next slide, we have some information on child care deserts. Next slide. If you have a chance and you're interested, check out this link, and you can look and explore whether or not there's a child care desert in your area. This is important because lack of child care services can lead to a lack of exposure to what it's like to be in a classroom, and for our more vulnerable kids that have behavioral health needs, that becomes an access barrier. It also makes it more difficult for them to make the transition into kindergarten effectively, and the ultimate goal would be to be able to have kids in an environment where they have access to behavioral health and mental health services. And the most effective way we are able to do that in our community is to provide those services within educational or learning centers and programs and schools. And so for our communities that are considered child care desert, they do not have the same access. And we know in our community that half of all the children are not having a learning environment or a school-like environment experience prior to kindergarten. Next slide. So our strategies, and all of this information, there's lots of resources. So this is sort of like the tip of the iceberg thing. Strategies our local schools are implementing to address the opioid epidemic: early childhood mental health consultation, school-based mental health services, so providing those treatment therapists in the schools for the children to be able to access, and having those therapists be a part of the educational team and seen as part of the team by the school districts. PACS Good Behavior Game, PBIS, Positive Behavior Interventions and Supports, which is promoted by the state of Ohio. We have a lot of traction. And Triple P is a positive parenting program, has a 19-year track record, and great research body behind it. Can be very effective as well to provide supports for parents. And then family engagement and care coordination, and these are both things that we're actively working on improving in our communities. Next slide. So the path forward includes lots more advocacy and awareness, and the promotion of early childhood mental health consultation, prevention, intervention. Again, I would refer you to our resources so you can look up more if you're interested in bringing this to your community. Next slide. Next slide.
That's it.
Yes. Okay, great.
Is she not seeing it?
Yes. Next slide.
You did, and you moved the slide.
Okay, thank you.
That's the last slide, Grace.
Okay, thank you. So the improving the cross-system integration and collaboration. So our project, our Safe Schools, Healthy Students project, has really helped us take a big step forward in cross-system integration, and we're ready to continue to that process of integrating the mental health and education systems locally. We're providing lots of professional development and workforce development because that's very much needed. Because people wear many hats, we're trying to cross-train as many professionals and educators that are interested, and having plans that address the specific needs of each of our rural communities is also important. So thank you. That is the last slide.
Well, Grace, thank you so much. So I wanted to, operator, if we could open the line for if there's anyone who wanted to ask a question of either Grace or Jen.
Thank you. Once again, to ask a question, please press star 1. One moment.
So again, while we wait for any of our participants or callers to get queued up, there are a number of resources that we've identified and for you all. As I mentioned, this particular presentation will be posted on the Rural Behavioral Health web portal within another week or so, and you will then be able to have access to the resources that we've listed here on this slide. Resources from the American Institute for Research and our Center on opioid use. There is also resources available from the Center for Disease Control, the Ohio Safe Schools Healthy Students Initiative, SAMHSA and USDA, and a number of SAMHSA resources that are available. Also resources available through the U.S. Department of Agriculture and from the U.S. Department of Health and Human Services. So we've provided the links for those resources here on this slide that you'll be able to have access to. And while we're talking about the access, I should again, and Laura asked you to also type this in, is the address for the Rural Behavioral Health web portal. The address is ruralbehavioralhealth.org. It's as simple as that. ruralbehavioralhealth.org, all one word.
Were there any questions?
I am showing no questions.
Okay. Thank you, operator. And we also see that there are no questions in the chat box, which means that Grace and Jen, you did a fantastic job and apparently covered all information needed. So, but I think we may have one here coming up. Okay. So there's a question that we have from one of our participants. Is there data for generation to generation, in other words, multi-generation opioid use?
There is. So, Karen, I can do a little bit more digging and get you some sources that you could put up on your site.
Okay, great. Thank you so much, Jen.
Yeah, it goes with that family, just so you understand where the data comes from. So it goes from that family use, what Grace and I have talked about with the family and the indirect impact, and then the behavior learning, and then what we see with actual use down the road. So. Okay.
Excellent. Well, thank you so much. Well, again, we don't seem to have any more questions, so just wanted just a few points here again, just to say thank you to both Jen and Grace for an absolutely wonderful presentation and for, your willingness to also answer a number of questions that our participants asked. I also want to take this time to remind you all that we have webinar 3 coming up in September, the early part of September. This webinar is entitled Addressing the Needs of Young People with Serious Emotional Disturbances Through a Comprehensive Continuum of Services. The webinar is scheduled for September 6th from 3 to 4:30 p.m. Eastern. And for additional information and to register for the webinar, please again visit the ruralbehavioralhealth.org website for details. And as you can also visit the the web portal to also gather information about other topics related to rural behavioral health. So in the minute or two that we have left, I'd like to also invite you all to provide us with your feedback about this webinar this afternoon. It is important that you give us your feedback as we use this information to help inform our planning as well as our